Greetings to all. I, Dr. Manish Rai, Assistant Professor at Sancheti College of Physiotherapy, Pune, welcomes all our attendees of 11th Scientifica, a virtual conference, with a motto of think scientific, think research, and think global. This year, our main aim is to bridge the gap between the different worlds of physiotherapy uh, across various continents. Mr. Fred Smedes from the Netherlands has overall experience of 36 plus years. Sir, from being private practitioner to chief of physiotherapy department at Rhine, Germany, has essayed such a various roles with ease. Sir has been igniting young minds as teacher at Germany as well as in Netherlands, and he has been course leaders for motor control and neural mobility since long. Sir has multiple international publications, and it is honor to host you, sir. Thank you so much for accepting our invitation. Now, using a neurophysiotherapy approach, a PNF, in the perspective of orthopedic manual therapy, is the best crossover one can get. And we have a fractionalist who's going to talk about it. And I know, just like me, all our delegates are eagerly waiting for your talk, sir. So, without any delay, I hand over the session to you. Thank you.
Thank you very much for your kind words and for your invitation. I'm happy to be there. Let's start.
Good day to you all. My name is Fred Smedes. I'm a physiotherapist in the Netherlands and I'm employed at the Saxion University of Applied Science. Furthermore, I'm also connected to the International PNF Association, and from that content I am asked to provide a lecture on this fantastic symposium and online conference in India. Thank you very much for the invitation. We'll have a presentation about PNF and the combination of PNF with orthopedic manual therapy. What are we going to talk about? I will provide a small, short introduction on the PNF concept, and then we are going to look at what we really do as physiotherapists and how much similarity is there in the various ways of performing our profession. What are we doing? What do we want to achieve? And what do we really achieve? And is there an evidence for our way of working? Let's first look PNF in the perspective of manual therapy. Well, this is me, and I use quite often the PNF concept. If that is wise, I don't know, because you end up like this. So you can ask yourself, is it then a wise way to use it clinically? You get a diagonal face. But let's look more seriously to the concept. The rehabilitation concept of PNF was founded in the 40s of the last century by Dr. Cabot and Mrs. Knott, Maggie Knott. It was originally developed as a rehab approach for multiple sclerosis and polio patients, but it developed in the decades after till nowadays. It is a total approach, a comprehensive rehabilitation approach based upon the analysis of activities of daily life, of sports, and we facilitate activities, but we also facilitate body function and body structures. So we go from facilitation to participation. When we look back in history and says, what did Maggie Knott already say in the 50s? It is skill and strength and endurance are developed by active participation in life. Furthermore, meaningful movements are the basis for a successful life and are coordinated and directed towards an ultimate goal. And that is basically similar to the wording of the modern ICF, but the modern ICF was only defined first as an International Classification of Impairments, Disability and Handicaps, the ICIHD, and in 2001 in the ICF. So 50 years before that, we already said it's about meaningful movement, and we need to have, of course, strength and endurance and skill to do those meaningful movements. Body function, body structure, in the activities to participate in society. So What do we really do as physiotherapists or as manual therapists? What is our motivation to be a physiotherapist, and what are our skills as a physiotherapist? So why do we do it, and what exactly do we do? Well, quite simply, we only push and pull. We take care of an attendant, a living person. That's the basics of therapy. And we do that with our hands. We influence with our hands. That's manipulation. Hence, manual therapy is the use of our hands in a curative, healing way. So even massage, that definition would be a manual therapy, but manipulations with a therapeutic intent is, of course, the real manual therapy. Can I manipulate tissue with a therapeutic intent? Hence, when I can take care of a living person. That's what we want to do. So what do we then really do? We only twist, turn, shift, push. That results in several different loading systems. Tension loading, compression loading, rotation loading. When we take a look at that, we'll see that tension is a kind of pulling force. Compression is the opposite. And when we give a torsion or rotation, as you can see in the middle here, we get, of course, again, a kind of force on connective tissue. When we bend, then one side will get stretch, tension, and the other side will get compression. And of course, we could give shearing forces, different modes of tissue loading. And that's basically what we do as physiotherapists with our hands, or what we do as human beings with our muscles on our joints and therefore on our connective tissue. That are the fundamentals of our manual approaches. Twisting, shearing, pulling, pushing. Quite simple. But it's always more. And we'll look at that. What do we now really do? We move bones against each other. That's defined as osteokinematics. That describes how peripheral bones move in relation to other bones, like flexion in the shoulder, abduction in the shoulder, and of course then the humerus, the scapula, and the clavicle will move in relation to one another or in relation to the thorax. But when we move bones, we move within joints, and that is arthrokinematics, the intra-articular movement or behavior of the bones towards each other. Hence, we get a caudal glide or a ventral glide or from the humerus against the glenoid, depending on what kind of movement we do. And that we can describe for any joint. But we only push and pull on bones, and therefore we push and pull on joints, and therefore we strain connective tissue in muscle, tendon, and in capsule, ligament. What are we basically doing? When we look at this and we say, look at that curvature that develops here in the spine because of movement of bones, osteokinematics, that would be a PNF pattern of scapula, posterior elevation, pelvis, anterior depression. But when I look, of course, not only on the whole spine, but on one segment, then I'll move over and say, hey, that one segment, I'll look at the joint as a manual therapist. And when I push the upper body part backwards and upwards and the lower body part forward and downward, then I get a rotatory component. And then we see that that curvature over here and on this side is quite similar, just a different focus. That's what we basically do. So we'll look at that in low back pain disorders, for instance, and we'll look from the manual therapy point of view, or to OMT point of view, then we'll look on the biomechanics of a joint. A thorax left rotation, a pelvis forward rotation, and a lateral flexion that will result in an opening of the left intervertebral joint, facet joint, an opening of the intervertebral foramen, and therefore a decompression all on the left side, based upon our biomechanics of the joint, arthrokinematics. But when I look at the same patient now with a reasoning from the biomechanics of muscle, then I ask, could you pull up your scapula? Could you push down and forward your pelvis? And I give a specific timing, so I emphasize that lumbar area, timing for emphasis. Then I get, of course, a similar arthrokinematic not the same, but a similar arthrokinematic result based upon the osteokinematic activation of the patient. And there we see already how PNF and orthopedic manual therapy could work together in a musculoskeletal context. So what do we basically want to achieve? We always want to achieve as PTs rehabilitation. What is that? Rehabilitation is the ultimate goal of it is to restore function, that's on body function, body structure level, so that a satisfying quality of life can be experienced. That means that I can use my body structures in activities in a specific context. Hey, that is quite similar as what might be not already defined in the 50s for the PNF concept. So what are the objectives? We want to have a live role participation with functional improvements. And we as PTs, we intervene at multiple lower levels on the pathology, on the impairments, to improve the higher levels of functioning and live role participation. So these principles also supported the incorporation of functional tasks in the clinical intervention. Functional task practice and the demand of attention for the task practice. The objective, according to the WHO, for rehabilitation is involvement in a life situation or the lived experience in the actual context. So the definition of the World Health Organization is not really different as what we already mentioned in the PNF concept or as a manual therapist or in our paradigm of healthcare as physiotherapists. So what is now the problem with a patient? He needs to participate, but we have a participation capacity and we have a certain participation performance. And quite often there is a gap between the capacity and the performance. So the capacity is the individual's ability to execute a task in a given domain at a given moment. And that ability is depending on the components of the ICF classifications, body structures, body functions, attitude, to be able to do something. But what is now the participation performance? That is what the individual really does in his or her current environment. And that means in his involvement in a life situation. And that's not always the same. Sometimes fear or circumstances are in the way of performing and not so much the structure alone. Sometimes the structure is in the way of performing. And then we as PTs are required for rehabilitation. So this gap is, of course, the body level or the impairment are primarily to be addressed. We look at lack of mobility, lack of force, lack of strength, lack of stability. And then we'll look on the performance, the capacity in the environment. Hence, either we change the environment and we provide people with crutches or with a wheelchair or with a prosthesis. And we influence the attitude and say you can still walk even when you have a difficulty in your leg. You have a total hip replacement, body structure. You had an impairment, you had degeneration in your hip. But now you have to learn to walk again with that hip. Hence, we'll try to close the gap between capacity and performance. And that is all according to the ICF. But that's a very famous overview of the ICF. Where are we intervening? In all these boxes, we can help the patient with his or her health problem. So the PNF philosophy says we should evaluate the situation and the goals for activity and participation. And we treat the total human being, a kind of holistic view. We'll treat the structural level, the activity level, and the attitude of participation in a functional way with meaningful movements. And that means we need to use the whole body, and we use principles of irradiation and overflow. So the activity is connected to the meaningful movements and the participation to goals of daily life. And we'll look now at orthopedic manual therapy and PNF in terms of clinical reasoning. Then we have to analyze a functional problem. We have to identify contributing factors, physical impairments, and context factors. And we address in the therapy these underlying factors. And we combine in our therapy evidence for our approach, our personal expertise, and the patient values. And we combine these three things. We have the definition of evidence-based practice, like Sackett defined it already in 1996 and published later in 2001, and others like Jette and all repeated that view for the physical therapy professions. So what are we really achieving? We affect these components of the ICF. And what do? We find tissue repair. We influence an inflammation process. We try to influence the collagen fiber organization. We influence the tissue fluid dynamics. We have an effect on the afferent of the nerves. So we have an afferent nerve fiber stimulation. And with all these components, we change the body function, body structure. So the patient is able to start doing activities. So when we look at that, say body level and or impairment are treated also with activities. So we have to improve by motor learning. And according to efforts in the Journal of Manual Therapy, already 15 years ago, learning of movement and its therapeutic application with patients through teaching is arguably the most central role of physiotherapists. So how do we achieve that with PNF? How do we achieve that with orthopedic manual therapy? Well, motor learning means we need a proprioceptive input. We have our basic procedures, manual contact, and there we see the similarity with manual therapy. We put our hands on, we provide resistance, approximation, traction. We use patterns of movement in a certain timing. It's all proprioceptive input. And those patterns are never the objective of the treatment. They are tools, so we do not perform the patterns, but we use the patterns to facilitate a muscle activation, so we move a joint. And we'll look at this, and we'll look at the basketball player here on the left side, and we turn him around, and we make him a soccer boy who has to go to mama and wants to ring the doorbell because mama, I'm thirsty, I need a lemonade. We see a similar pattern of movement with a different intent and a different amount of force. Then we'll look at this nomad, and he's pouring in a cup of tea or a cup of water on his fire. Then we see, of course, he needs to lift his arm against gravity. Means he's doing a flexion in his shoulder, an abduction in his shoulder, and to hold up the pot and therefore work against gravity, he is active in an external rotation. Even when he pours in the water, it will be an eccentric external rotation activation. The same for his wrist. He has to hold up pot with hot water, means he has a wrist extension, but when he pours it in, he might lower the wrist down to flexion, but it is an eccentric activation of the wrist extensors because of gravity. So we have to look on the pattern of muscle activation to do a task. And we then look now on motor learning, then we do not only provide input, we ask a neuromuscular output. And therefore we use our techniques. Like I just showed on the nomad who was pouring in his tea, he needs to learn the movement, but he also needs to control the gravity. And he has to combine, in the combination of isotonics, the contraction of concentric to lift the pot, static to hold the pot, and eccentric to lower the pot of water and pour in water in his cup. Motor learning. Motor learning is not a technique, it's a process. So the patient needs to work and experience with mistakes, solving a problem of a functional task, and it should lead to a relative permanent change in motor behavior. So is there evidence for this approach? Well, then we only have to look and say, is there research for it? Do we have a certain clinical expertise and what is the patient asking from us. Well, the research, that's one thing. The clinical expertise, that's you yourself, me, myself, in adjustment with your patient. That means every session, every treatment session with every patient can be different from each other. You do not need to copy paste treatment A to treatment B, or the treatment A on patient 1 identical on patient 2, because that patient might have different patient values. So when we look at that, we studied literature, and we do that over 15 years now. We did a study on PNF literature, and we updated it every year again. You can find that easily on the ipnfa.org/literature. And we published a narrative review on the state of the evidence in 2016. And maybe we will redo that in, say, 5 years from now, when we are in 2026, and see what and how was the state of the evidence changing? How did it develop in that decade? So there is evidence. Can we use it? Well, when we look at it and say neural adaptation to resistance exercise, because resistance is one of the key factors. We always have to control our body against gravity. We always need to control objects against gravity. To lift it up or to put it down, we control gravity, hence the resistance of gravity. Or we control friction. When you put a comb through your hair, you have friction. When you put an arm through a sleeve of a coat, you have friction. When you put a knife in a slice of bread, you have friction. When you put a saw, etc., you have friction. So we need resistance. And we achieve with that resistance motor unit synchronization. We have a mental practice training, and we get a cross-transfer effect. That means when I use my right arm, even my left arm has benefits from that, and vice versa. Let's have a short example. And is there evidence for it? Well, COVID told us, they studied PNF in chronic low back pain. I have an example here of a lady of 63 who got a total hip operation, had a lot of low back pain in that part, and I'll combine PNF and manual therapy. Let's have a look at that. You see here the lady with her back pain. I'll go for a manual mobilization, but you recognize already this is similar as what I did on those photos where I said, what is the comparison between manual therapy, what I'm going to do now, or PNF therapy, what we are going to do any moment. So here we do a lateral flexion rotation, and I'll give the manual impulse over the pelvis, and with my finger and thumb I'll define the location, and now we have a PNF pattern of anterior depression. And we can go on with that. So just to have an impression on that. Now there we go. So we have another clinical example. We'll look at a patient with a frozen shoulder. And of course, hey, the idea is I want to brush my hair. Structural impairment, limited range of motion. And I need a flexion, abduction, and external rotation with an elbow flexion to do this functional task. I would like to do hold, relax, and combination of isotonics. And when I look at that, then I will see that basically when I do that with a timing for emphasis, and I emphasize on the external rotation, I basically have atriokinematic, a spin, and a caudal glide in the glenoid cavity. When we take that as a picture, you will see here the lady has to brush her hair with that frozen shoulder. So the brush is going backwards, as you can see, and therefore she has a little bit more external rotation. It's a pattern of PNF, but it is also a spin movement in the glenohumeral joint. When we look at hemiplegia and say, wait a minute, that's neurology, but every neurological patient has musculoskeletal components. Every hemiplegic patient has bones and muscles, and they get stiff. So there's a lack of finger and hand extension. There's an immobile carpal system. That means maybe from a manual therapy point of view, I would mobilize the scaphoid, the lunatum, to get more functional hand-wrist extension. This was published in 2014. So we go on and say, wait a minute, that patient should, of course, do that functional, roll glide mechanism of the scaphoid in the wrist for wrist extension at the moment it is required to reach, for instance, for a cup of coffee. So basically, I have to combine joint techniques and functional task training with a specific timing to emphasize wrist extension. And there we see we have additional manual therapy, functional task training with a timing for emphasis in a pattern of flexion, abduction, and external rotation to reach. And we did this study on a group of 20 patients. One group got a combination of manual therapy and timing for emphasis, and the other got just functional task training like the guidelines for stroke tell us to do. And we said, what would be the benefit of combining manual therapy and functional task training in a more goal-oriented treatment? And see there, the OFT and PNF is helpful. And we'll look at the results. Then we see in blue the red, the MT group and the control group in red. And this is the development of the passive dorsiflexion, so wrist extension on the affected side. As you can see, hey, that goes clearly up. When we look at level of skill with the Frenchy arm test, then we also see that the intervention group got specific passive mobilizations in the wrist, got an improvement and maintained that improvement. And between 2 and 3, that was the retention time, but there was no intervention. So the first part of the intervention time, the second part was the retention time on both sides. And then we see that it is beneficial to do structural interventions even in functional problems in neurology, because these patients have a musculoskeletal component. We have a last example, I believe. This is about a slap lesion in a young lady playing handball. We have a secondary impingement, and I'll do again a caudal glide mobilization on the glenohumeral joint in combination with PNF. Let's have a look at that as well. So we don't go for a caudal glide and abduction, as you can see here. And I'll ask her now to lift the arm up actively while I do a caudal glide. I'll ask her to open her wrist and fingers in the next session. There she comes. So she had some active osteokinematic movement, and I'll provide with my hands the caudal glide arthrokinematics. Second part, what we see here is that that lady had clearly a ringing scapula in the eccentric. There she goes, there's the ringing. And now I'll provide resistance, and I'll still ask her to lift her arm up against my elbow. So I give resistance with my elbow on the arm. Verbal command to push me up and eccentrically go down, and then I let go of the facilitation, and then there is no ringing scapula anymore. So we see that you can really nicely combine manual therapy and PNF therapy in a functional context. This is not what I wanted to do. My mistake, sorry. There we go. So we need to look at the reasoning. PNF and orthopedic manual therapy, we do, of course, make capsule stretches. We have an afferent influence on proprioception, on muscle recruitment, and we do in both approaches a lot of functional rotation techniques. And that means we have a mobilization effect and a stabilization effect. So you could conclude that PNF can contribute to achieving participation, especially by influencing the participation capacity. There is scientific support from several levels of quality for on impairment and activity level, and the clinical use of PNF is quite well documented. From a point of view of a therapist, the end positions are similar. When we look at PNF or we look at manual therapy, the end positions of a joint or the osteo and arthrokinematics are quite similar. There's a good combination of treatment techniques within one therapy session. You could say joints are moved by muscles and controlled by the central nervous system, so there is no contradiction between manual therapy and PNF therapy. The recommendation for researchers would be, from my point of view, focus more on similarities instead of on differences. Don't study always what is better, this or that, but when from both is documented that they are beneficial, maybe explain why both are beneficial and look for the similarities. So we could say PNF and manual therapy are in perfect balance. I will give you a short overview of the used literature. Of course, it started with Maggie Knott from the PNF concept with her publications of 56, 68, 84. Then the fundamentals of manual therapy in 97, the ICF early 2000, and then thinking in more perspective than just one. Look for similarities in the various PT methods. That's something I published myself in the Netherlands, Physiopraxis 2004. Evidence, of course, is important. Motor learning is important. Think of Schumbury and Cook and Kleinen, 2018. And the narrative review on PNF qualities, how much is available, 2016. Kovatoulis and Arudembong studied the effect of PNF in chronic low back pain in both in several years in the last decade. Management of musculoskeletal components also require motor control according to Marjorie and Jones. I myself did with a colleague a scapular motor control training with PNF in subacromial impingement syndromes that was published last year. And with that, I hope you have a nice impression. And the last one on the bottom is that hemiplegic manual therapy intervention process, what I demonstrated. I would like to thank you for your attention. So are we talking about functional participation, or are those guys just protecting their offspring with their legs and knee? But okay, that's just a joke at the end. Thank you for your attention.
Yeah. Thank you so much, sir. It was like visiting your years of experience in few minutes. The talk was very beautiful blend of words from your heart and clinical expertise. I'll be repeating myself, sir. Hosting you for 11 Scientifica has been such a pleasure. Thank you so much for joining us.
You're totally welcome. I enjoyed presenting my view on our profession to all of you. I hope you benefit from it. Thank you very much.
Thank you.